Hi, everyone. Welcome to After the Diagnosis, a webinar series presented by the Neuroscience Family Advisory Council at Boston Children's Hospital. I'm your host, Dylan Kirsch. In this webinar series, we'll be talking to patients, caregivers, and providers about diagnoses that we face and giving it a completely different perspective. Today, in this episode, we're going to be discussing, pardon me, this is a tongue twister, but opsoclonus-myoclonus syndrome, or just OMS. We have three different participants, each with a different background, and we're super excited to get started. So let's take a few minutes super briefly and just kind of introduce each other. Again, my name is Dylan Kirsch. I'm a first-year clinical research assistant in the Department of Neurosurgery here and the co-chair of the Neuroscience Family Advisory Council. I used to be a patient here and have kind of been through all sorts of different roles here. And hopefully after my 2 years of doing clinical research here, I'll be headed to medical school. Dr. Gorham, why don't you introduce yourself?
Hi, everybody. Mark Gorman. I'm a pediatric neuroimmunologist here at Boston Children's Hospital. I originally grew up in Queens, New York, and made my way to Boston for medical school and have been at Boston Children's for my entire career, from residency to fellowship, and now leading the neuroimmunology program.
Fantastic. Kitty?
Hi, I'm Kitty Petty. I'm the education specialist working in the Neuroimmunology Center. So I was a special ed teacher and then was a regular ed teacher. Actually, at the age of 6, I wanted to be a teacher because my father was a teacher. So I became a regular ed teacher, then a special ed teacher, which led me to becoming a special ed consultant for children with special needs for Fortune 500 companies. And then ended up deciding that because of all of the challenges that children with special needs have and medical problems, because they often have a lot of behavioral and emotional problems, that I decided to get a second master's, and I became a licensed mental health clinician and ended up being an intern at Boston Children's Hospital in the learning disabilities program. I was the first special ed teacher in the group. It's a team approach, and they hired me. And about 5 years after that, I was asked by the director of the learning disabilities program to help a young fellow who was starting a new clinic as he became a neurologist in the neurology department. And he was working with children who had multiple sclerosis, and that person ended up being Dr. Mark Gorman. So we've been working together since about 2006 through all the different illnesses, and we work together well.
Wonderful. And Jessiree?
Hi, I'm Jessiree. I am the program coordinator here in the Neuroimmunology Center. I do have a background in social work and psychology. My background is also working with children as well as interning here during my bachelor's, then working with adults with disabilities and back into the healthcare here, working with pediatrics. Fantastic.
Thank you. So, I'm in neurosurgery and we're kind of tucked away in our little corner. And I'm curious, I'm genuinely curious, what is the Neuroimmunology Center? What do you guys treat? Why would somebody come to you guys for care? And I'm leaving that open to anybody who wants to answer.
Yeah, so I can take the first shot there. So broadly speaking, neuroimmunology involves disorders where the immune system is confused and attacks the brain. There are many different autoimmune conditions, some of which are more well known in the community, like type 1 diabetes, for example, is an autoimmune condition that affects the pancreas. But here in neuroimmunology, we're dealing with autoimmune conditions that affect the brain. And the most well-known of those is multiple sclerosis, which is a disease that most commonly affects adults, but can affect children. So we see patients with multiple sclerosis and related conditions, but particularly in pediatric neuroimmunology, there's a very broad spectrum of conditions. It's certainly not restricted to multiple sclerosis. And so having started the program here in 2008, and making a conscious effort to see all of the patients with these various conditions. We have a very wide breadth of experience, and we see all the different conditions that affect the central nervous system in neuroimmunology. We've grown over the 14 or 16 or so years that we've been in existence. So we now have 5 different neuroimmunology attendings, all of whom are pediatric neurologists and all of whom are fellowship trained in neuroimmunology. And I think that's really important when a patient and family are looking to try to match with a provider. I think that we all have that unique and special expertise of combination of pediatric neurology training and neuroimmunology. In addition, because we're a relatively large program, we've each been able to specialize within specific areas of neuroimmunology. So you're getting really, a patient who comes here gets very deep experience in their particular condition. In general, if you have a pediatric neuroimmunology condition, we have seen it before, and we have probably seen it many, many, many times. And so I think the main reason to come here, I think, is the deep clinical experience that you get. But it goes beyond that. As Kitty mentioned, we've been working together. 2006, I started my fellowship. 2008, was when I could formally say that we had started the neuroimmunology program. So yeah, we have been working since 2006. And that was really key right from the start of having a multidisciplinary approach. So we know that these conditions not just affect the patient's medical care and medical condition, but they can affect them in school, at home, in the community. And so we wanted to make sure we were taking care of all of their needs, as well as the family's needs. So I would say deep expertise and multidisciplinary care are 2 of the top reasons for patients to come here.
And just quickly, you kind of mentioned how each physician has their own subspecialty or sub-interest within kind of the broader field. Does your research also correlate along those lines? Like, are you, really focused in terms of your research on your, subclinical specialty?
Exactly, yeah. So as the field has grown, it's really quite exploded over the past 10 to 15 years. And along with that has come extensive amounts of new knowledge, which has opened up for new treatments as well. And so we really pride ourselves on trying to make a precise diagnosis, which oftentimes will then lead to a precise treatment. And that's definitely informed by the research that we carry out. And each of us is actively engaged in clinical and translational research within our own specific area, which for me over time has become opsoclonus-myoclonus ataxia syndrome. And so that's become my main area of focus.
Well, that's the perfect transition. So let's talk about OMS. Kind of in your words, what is it? What are kind of the common symptoms that kids are coming in with? And what does the diagnosis process look like?
Sure. So yeah, we can kind of walk through each of the words in the name of the condition first and explain what they are. So the O stands for opsoclonus, which are these uncontrolled, chaotic, abnormal eye movements. And so back in the day, the condition used to be called dancing eye syndrome because the eyes look like they're dancing. They're moving all around. So that's one symptom. The M or myoclonus is jerking movements, which can superficially potentially resemble seizures, but are not seizures.
Okay.
And then the A is ataxia, which is being off balance. In addition to that, most children will have irritability and sleep disturbance, as well as changes in their language function.
Okay.
Of those symptoms, the most common to present with is the ataxia, or being off balance. And so typically what will happen is parents will notice a change in their child, and the average age of onset for this condition is between 18 and 24 months. So these children usually have already learned how to walk, are becoming better at walking, even running, but then have a clear and distinct change in their balance. They seek medical attention. And then, unfortunately, a lot depends on the experience of the provider that they see, in terms of whether or not something like opsoclonus-myoclonus ataxia syndrome is on their radar screen. So because it's a rare disease, many providers have never even seen a single patient with it. And so oftentimes it's initially misdiagnosed. Thankfully, over time, as with increased knowledge and education, the time to diagnosis has improved. But the diagnosis right now is really based on clinical symptoms. In addition, approximately 50% of the patients have an associated tumor.
Interesting.
You might think, oh, this is a neurologic condition, so maybe it's a brain tumor. It's not a brain tumor. It's a tumor that's somewhere in the body, typically in the chest or the abdomen. And part of the job of the immune system is to fight against cancer cells.
Right.
What the immune system does is that it fights against these tumors. It does a really, really good job at controlling the tumor, but unfortunately it cross-reacts with the brain and then produces these symptoms.
So it sounds like in some of these cases, it's a misdirected immune response that's kind of causing these symptoms.
Exactly.
Okay. And then in terms of treatment options, is that kind of coinciding with, I mean, for example, like the tumor treatment, is it similar? What does a child look for or a family look for in terms of treatment?
Sure. So the first thing is making the diagnosis. So seeing a neurologist, we would always get a brain MRI, which quite surprisingly, but typical, the brain MRIs are normal in these patients, despite having really significant symptoms. And then we would look for the tumor with a variety of different imaging techniques. If we find a tumor, then we engage our colleagues in oncology and general surgery. But simultaneously, we're lining up to do anti-inflammatory treatment to try to dampen down that overactive immune response. And we try to start early, and we're pretty aggressive with our treatment to try to get on top of that inflammation.
So it sounds like it's the treatment is definitely done on the earlier side. This is not necessarily a condition that can wait.
No, this is not something that you want to sort of wait and see what happens once you've made the diagnosis. You want to really get going. One, seeing if there's any tumor, and if there is a tumor present, then working on getting that resected, and then simultaneously starting the anti-inflammatory treatment. So some of our patients come through, in the local community, and might come through the emergency room, and get funneled into care that way. Some patients may, have been diagnosed locally, and then seek out our expertise and reach out, to Jessiree as the point of contact.
And to your point, I think it's such a testament to your previous discussion about how the clinic is so multidisciplinary, right? It sounds like OMS is one of those things that it's not just one physician or one center that's really taking care of the child. It's kind of communication across a bunch of different specialties, it sounds like.
Yeah, absolutely. And it changes, with the phase of the disease. So there are certain providers and certain specialties that are key at the beginning, and there's different ones that evolve over time. With us being at the center of it the whole time and coordinating that patient's care, because it can be overwhelming, to try to see all these different specialists.
Of course.
And so we take the lead in kind of, being the quarterback of the team. Early on, particularly if we identify a tumor, the other key specialists are oncology. And so we're fortunate to have Dana-Farber Cancer Institute right next door. And we have, world-renowned experts in the type of tumor that are associated with opsoclonus. That tumor type is called neuroblastoma. So all of our patients who are diagnosed and have a tumor would see one of our neuroblastoma experts.
Yeah.
And we also have partnered with general surgery, and in particular, one particular surgeon, Dr. Wheel, who does all of our surgeries. And many surgeons will not know what opsoclonus-myoclonus ataxia syndrome is.
Right.
But Dr. Wheel has performed surgery on many of our patients and knows, for example, that if it's safe to do, that getting a full tumor resection is really important.
Yeah.
And so that's also a key partner that we have in the early days. As the patients get past that acute phase, then we also partner with physical therapy and occupational therapy. And then in the longer term, unfortunately, some patients can have cognitive and behavioral sequelae. And so we partner with neuropsychology, psychology, social work. And Kitty is with the patients really from the beginning, also helping to make sure they're accessing the resources that they deserve, kind of ranging from the early days where that might be through early intervention, and then through the early school years upwards through college. And Kitty has helped patients and families be guided through that whole spectrum of education and services.
Which I think is, so important as we, this is a pediatric institution, and right, kids are just, it's not just their disease or their disease process. They're living in just like this larger world where education and sports and their extracurriculars, the things that they're interested in, are not just an afterthought, but they're important. They're kind of central to that child's identity and development. And I think, just speaking across, not just you guys, but all the specialties, it's about like maintaining that focus on that as well, which I think is why we have amazing people like Kitty and Jessiree with us. Switching over to you guys, I'm curious. I'd love to hear from you both about your experience working with patients and their families, and kind of how your roles are similar but also different. So please, I would love to kind of hear briefly about your experience.
So I'm going to start. As I said, I was a special ed teacher, and then I became a licensed mental health clinician. My first job with these patients is to help normalize it for the parents, to really try to get them to realize, okay, your child is sick. Now, what are we going to do about school? Are they going to go to early intervention? Do they need OT? And just to try to make it just ground them into, let's go forward. We hear some suggestions to try to get them to begin to understand what's going on, and then offer my support throughout their entire school life. So many children with OMS, as Mark mentioned, have behavior problems. So one thing I do is, I was a behaviorist to a certain extent. I worked a lot with kids with significant emotional and behavioral issues. And so I can give the parents some suggestions about how to handle the incredibly difficult behaviors at home. And I can also explain what to do about, just insignificant rages, or, they have a challenging time, but I can help the parents. And sometimes I will work with the parent and and I do it mainly by phone because they're at home and I'm at the hospital. And so the parents can call me at any time. And they say, okay, he's under the table right now, and I don't know what to do. And so I just talk them through it as calmly as I can. And they just are so appreciative and so thankful that I'm there to help them. The other thing I want to say about OMAS children is they often have a tendency to have difficulty with reading. So I ask them to monitor it very carefully so that I can step in and make sure that they're getting their best intervention possible so that they can become strong readers. And I've helped lots of our OMAS children manage that, to get over becoming really struggling reader to a pretty competent reader. So that's been helpful. And then I just think I'm there for the parents and the schools. I wrote up an information sheet for schools to help them understand OMAS and how it impacts them cognitively and emotionally. And it's been very helpful, I think, for the schools, because they They've never heard of it. They have no idea what to do, but it's pretty practical information. So that has helped.
Right.
And so that's basically what I want to do.
I love your point about the schools. And as another aside, one of my research focuses, especially in my undergrad years, was brain injury in schools. And it's kind of the same sort of thing, right? Where, these kind of longer term injuries, disease processes, especially for kids, a lot of people see them as like a strictly medical thing, but it's also an educational issue, right? Because the child spends so much time at school, right? It's something like 90% of rehab for a brain injury, for example, is done at the school. And so it doesn't necessarily have to be a medical condition. It is, absolutely. But there's also this other aspect which I think you touched on so well, which is, okay, how do we guide this child through the rest of their life?
That's absolutely what I try to do. And I enjoy every minute of it.
Good. Jessiree, tell me about your role and kind of your experience working with patients and families.
No, definitely. So as we've kind of touched on, that this experience can be kind of overwhelming for some families, especially initially. I try to be personable with the families and the patients, kind of giving them compassion and being empathetic, because, I mean, it's a lot.
Yeah.
And kind of one of the challenges is how do I get over the overwhelming feeling, right?
Right.
And how do I navigate? But lucky for them, we're here to help. I'm here to try to help them coordinate all their appointments and kind of have that collaborative approach in the sense that letting them know that we're okay, and throughout this journey it's going to be difficult, but we have many resources to offer to make that easy. So if that's working with Kitty, our social work, or any other resources that we can offer, definitely just being there and supporting them in every step of the way.
You kind of see yourself as, or find yourself in this kind of frontline role that, this is the person that kind of, picks up the phone and say, hey, like, we're here for you.
Definitely. I like to say that we're the, how do I say this? I feel like they look forward to speaking to a live person, right? There's that live component, and I'm real, right? So they come to clinic and they see me and they see everybody in this team, and they're just like, oh, you're that person I've been talking to, the person I may have cried to, the person I may have yelled at to, like all these emotions, and it's okay because we're understanding. And again, it's that compassion and being empathetic and
completely.
That,
and I think
we're here.
I see it in our clinic all the time. You guys are really often like the first line of people calling and saying, and when patients do come in for, I see it all the time here, for clinic or surgeries, you guys are often there, like regardless, just because you've kind of built up this rapport and this relationship with people. And I think that's so special, especially with a kind of niche diagnosis, a niche, quite, rare diagnosis that kind of can freak people out. So I know Kitty kind of talked about education and this behavioral aspect, but Jessiree, what do you see as kind of the biggest challenges that patients and families kind of face during their journey?
Grasping everything, the new, the unknown. What resources, again, are there, if there are any? It's a learning experience. I feel like from the initial conversation, it's just like, okay, you told me this, now what?
Yeah.
Am I here? What's the next step? And I think throughout our communication with each one of us, eventually the biggest challenge initially just isn't a challenge anymore. I feel like it kind of plateaus, and it's just like, okay, I'm okay, we're okay, my family's okay, the patient is okay.
Yeah.
So I think that's a big one. Just getting to know what the journey is going to look like.
Yeah. So kind of moving our focus past treatment, like we've said, much of the focus for patients and their families is what happens after. Like, is my child ever going to return to kind of that quote unquote, we don't like to use the word, but normal life? And so Kitty and Dr. Gorman, I'm curious to hear, at what point do our children returning to school, to sports, to their extracurricular activities? Is that coinciding with treatment? I'm kind of curious in your experience, kind of what does that look like for a patient?
Yeah, so, in terms of after we make the diagnosis and start a treatment, the treatments are fairly intensive. So we typically use 3 different forms of anti-inflammatory treatment, one of which is a monthly infusion, and so which is called intravenous immunoglobulin, or IVIG. And we're typically continuing the patients on some form of treatment for upwards of 2 to 3 years, if not longer.
Okay.
So, it's a long journey, and we're not going to be like putting the rest of life on hold just because of the diagnosis and the treatment. So our approach is always to try to get them back into their school and regular activities as soon as possible. We do take, some reasonable precautions to try to reduce the risk of infections. But that said, we don't place any major restrictions on them attending school and doing their activities. I think maybe I'll turn over to Kitty after I say this part, but I think getting the children and the families back into as normal of a routine as possible helps with their behavior and with their overall development.
Well, I'll just add that Mark is absolutely right. So the sooner, do you want me to keep going? Yes.
Please, yeah.
Okay, so the sooner they can get back into a normal routine, the better for the child and for the parents. So I spend a lot of time even speaking with the school, but helping the parents understand what an individualized education plan is, because most of them need to be on it because they need additional support.
Right.
As well as reading a lot of school reports and just guide the parents through that whole special education process, which is quite lengthy and quite daunting for parents. And so I'm there for them and helping them. And then I think that, again, with the schools, sometimes I get calls from the school nurse saying, well, what are we supposed to do? We don't know what to do. And so I just try to talk them through it and explain it. They've read the tip sheet, but they still are saying, do I have to check on him every hour? Do I need to should he go out to recess? And we all say, yes, normal,
Please,
do it normal as you can. But sometimes schools are not so helpful. So I have to help them, and I have to help the parents learn how to work with the schools to help them be more positive and working together. And, it's a process. I think we get so many younger kids, and then they go through elementary school and that goes okay. Middle school can be a big jump, and so can high school and even college. So they continue to need some support and a lot of accommodations as they get older, even in college, but they can be very successful.
Good. So I think, one of the things that I struggled with after my own injury and after my hospitalization here was the fact that, I had a brain injury when I was 17 years old, and I didn't really know anybody else who had suffered or sustained one. And so there was this semblance, and I think we see it a lot, of a little bit of isolation where I was like, I don't know who to talk to about these things that I'm feeling. And one of the things that I found really, really helpful were patient advocacy groups. Have you guys worked with any patient advocacy groups that you would recommend that kind of are able to link people together and say hey, this is what we're doing family to family?
Absolutely. So when I first started to see patients with OMAS, it was during my fellowship, and the mom of one of my first patients was very active in the patient and family community. And they introduced me to a group called the Dancing Eye Syndrome Support Trust, which is an organization that's based in the United Kingdom and was founded by parents of children with OMAS. And that group had meetings, internationally attended meetings in England every 2 years that I was fortunate enough to attend and have been attending ever since. So that was one of the main patient and family groups. at the beginning. And then over time, a few years ago, our colleague and friend Mike Michaelis, who's a grandfather of a child with opsoclonus-myoclonus, founded the OMS Life Foundation, which is based in the US, and has done a tremendous job in offering support and resources, and supports research into OMAS. And so they have a great infrastructure to help support patients and families. So I always direct our newly diagnosed patients to the OMS Life Foundation. The OMS Life Foundation has periodic in-person conferences for patients and families that Kitty and I have been fortunate to attend several of them, and talk about what we do, talk about the sort of state of the research, and connect directly with patients and families. Many of whom we've met here at the hospital, but some of whom, you know, hadn't yet come. Some of them come after we meet them at the meetings, and some who live from quite far away.
Fantastic. Kitty, did you have anything to add?
Well, I also am part of the International OMAS group, and so I'm the education specialist for them. And
Fantastic.
then really have found that Mike Michaelis has the weekends that we have with the OMAS parents, the children are off somewhere, but the parents are all there, is fabulous, because I've talked with so many parents, and then all of a sudden they're seeing another parent who's gone through the same thing.
Right.
And it's been a real bonding situation for them to see each other in person. And they just are they have lots of questions, and but it's a very productive time.
Good.
So I find that to be really helpful. I mean, because I'm an educator, depending upon their needs, I will send them to other educational websites that are very helpful. For example, one of them is ldonline.org, which is the best learning disability website in the world. And it has just practical information that is very helpful.
Yeah.
So I just keep them all going as much as I can.
Good. So as we wrap up, I would love to hear kind of like a 1 or 2 sentence from each of you, you know, take home message. If you were to tell a parent or a patient one thing about OMAS, what would it be? Like 1 or 2 sentences, Reader's Digest. I would love to hear one from each of you guys.
I'll break the ice. I think that early time is very, very important.
Yeah.
And so I think, and because it's a rare disease, I think one of my take-home messages would be, if your doctor is suspecting a diagnosis, or if the diagnosis has been made, seek out an expert who has seen OMAS before, and who has experience in knowing how to treat it.
And I think I'd say that their OMS children are all different. Even though it's the same diagnosis, they all end up with different different things that are working really well, and different things that are not working very well. So it's really you just have to go with the flow and try to figure out what's going to help that one child, and use your, some suggestions from other children that you've worked with, but it's always a work in progress.
And then to end it, I will say, all in all, you are the best advocate for your child or family member. And wherever you decide to get your care, there's always people that are willing to listen and help throughout the process.
Well, guys, thank you all for such a fantastic conversation. I learned a lot. I had a great time. Please be sure to head to the Neuroscience Family Advisory Council's website, which will be linked below, for more resources and information. And please stay tuned as we announce more after the diagnosis episodes on more neuroscience topics. Thank you guys again. This was fantastic, and I really appreciate your time.
Thanks so much, Doug.
Thank you.